Ashley.
And I'm Diane.
And we will be talking to you about central venous catheters today. But before we get started, a little bit about ourselves. Both Diane and I are the CPPN facilitators for the Vascular Access Management class that you are currently taking. I was hired here at UC Davis back in 2007 as a student nurse extern in the ICU. I was then hired as a new grad into the same ICU where I have spent the majority of my years in critical care as one of the educators between MSICU, the transfer and receiving unit, and Blue. I have also done some teaching with 2 local nursing schools within our facility. Back in 2019, I came out to CPPN. Diane and I were lucky enough to come together. So we've both been here at CPPN for a little over a year and loving teaching. I'm going to let Diane talk a little bit more about herself.
Hey, thank you, Ashley. Yes, we absolutely love CPPN. So a little bit about myself. I started here also as a new grad and I've been here since 2002. And I started on the orthopedic floor that used to be on East 4 and currently is now Davis 14. I spent 2 years and I was part of that whole transition. And then I went down to the surgical ICU and I spent about 13 years there. And I did a little bit of post-discharge call, came back to the hospital and did a year in radiology. And so here I am with Ashley and we've been loving CPPN here.
So hope that we entertain you over the next 45 minutes that you're with us talking about central lines. Enjoy. So listed here are the learning objectives for our presentation. We're going to go over the nurse's role in non-tunneled central venous catheter insertion.
And then we're going to list the indications for placement of a non-tunneled CVC.
We're going to state when administration sets and caps need to be changed per policy.
And the last thing is that you're going to be able to describe the correct position when removing a non-tunneled central venous catheter, and then who by policy can remove that line.
So some of this information is going to be a review as central lines are a commonly utilized catheter, but I hope that you walk away with at least 1, if not 2, pearls of wisdom from our presentation. Enjoy! To start us off, we're going to look at what a central venous catheter is. A central venous catheter, abbreviated CVC, is commonly referred to as a central line. A central line is an IV catheter that is threaded into the central vasculature through the neck, chest, groin, or arm. These long, flexible catheters empty out in or near the heart, allowing the catheter to give the needed treatment within seconds. A central venous catheter can remain for weeks or months, and some patients may receive treatment through the line several times a day. I want you to ask yourself, why would a patient need a central line? What are the indications that would require them to get a central line placed? What are our facilities' indications for placing a central line? So here you can actually see all of those hospital-approved indications to get a central venous catheter. Per the Venous Access Master Policy, which is Policy 13001, these are the hospital-approved central venous catheter indications. The categories include certain therapies and medications, treatment, and also access. So for the certain therapies and medications, this includes resuscitation, vasoactive infusions, continuous antibiotics, or antibiotics that are prescribed for more than 14 days. It also includes chemotherapy, total parenteral nutrition, and hemodynamic monitoring. For the treatment, those indications include transvenous pacing, plasmapheresis, apheresis, hemodialysis, continuous renal replacement therapy, along with other treatment modalities. Then there is the need for access. This category includes your palliative care and end-of-life patients, the need for multi-lumen access, such as use in the operating room, frequent lab draws that are either 6 hours apart or less, or anticipated for greater than 48 hours. Also, if peripheral access is exhausted or a midline catheter is not an appropriate alternative for this patient. Now that we briefly looked at the different indications there are for central lines, let's go ahead and go into the different types of central lines there are. There are many different types of central lines that you may see in your practice. Are major types of central lines that you may come across in our facilities and the corresponding policies for the care and management of these lines. So you have your pulmonary artery catheters, your non-tunneled catheters, your tunneled catheters, your peripherally inserted central catheters, also known as PICCs, your implanted venous access ports, and also your dialysis and apheresis catheters. Later on, we are going to discuss PICCs, ports, and dialysis catheters. So the remainder of this presentation, we're going to just briefly touch on pulmonary artery catheters and tunneled catheters, but mainly we're going to focus on those non-tunneled central catheters, as they are the most frequent lines that you guys are going to run across in your practice in regards to central lines. So let's go ahead and dive right into that brief talk about pulmonary artery catheters and percutaneous sheath introducers. So let's talk about these pulmonary artery catheters. They are also known as SWAN, Swan-Ganz, PA-Cath, or PAC. They are used to determine hemodynamic status in critically ill patients and are used to aid diagnosis and guide therapeutic intervention. This includes administration of fluids, diuretics, and also vasopressors. Care of these patients should be in a critical care unit, as additional training is required to manage these catheters. They are inserted at the bedside. They can be inserted in OR, and also they can be inserted in cath lab. The procedure does need to be performed by a physician with the assistance of the bedside nurse if it is done at the bedside. The catheter is inserted through the use of a percutaneous sheath introducer, and after insertion, the correct positioning needs to be confirmed by X-ray. So you can see by the picture here that the PA-Cath is floated through the right atrium, through the right ventricle, and into the pulmonary artery where it terminates in order to get those hemodynamic numbers. The percutaneous sheath introducer is also known as a MAC, a Cordis introducer, and sheath. So once that pulmonary artery catheter is removed, the length of the catheter is now only 10 centimeters instead of 20 centimeters. So it is actually no longer considered a central line once that pulmonary catheter is removed. You can see here by the size of the introducer that I have in the picture on the upper right. Look at the size, the thickness, the length in comparison to a 20 gauge peripheral IV and also a penny. So you can see how large that size is. So this is one of the reasons that they need to be discontinued when they are no longer being utilized. These introducers should actually be replaced within 24 hours or discontinued, as they are not meant to be in dwelling lines. Potential issues of leaving them in place include biofilm growth, as these sheaths don't actually have an antimicrobial coating, and also they are prone to kinks due to their short length, which leads to clot formation and the risk of clot embolism. Outside of the ICU and the ED, these sheaths may be used on Davis 6th and East 6th, with the exception of CT service patients.
Now we will be looking at non-tunnel catheters, which are the central lines that you may more frequently use. Non-tunnel centrovenous catheters are intended for short-term vascular access device for up to 29 days in the acute phase of an illness. These catheters are inserted by a direct needle stick into the venous system by a physician. It is commonly inserted at the bedside, but can also be placed in other areas such as the OR, the cath lab, and IR. After placement, the catheter needs a X-ray verification prior to it being used. The catheters are made of a radiopaque polyurethane or silicone with single or multiple lumens for infusions and monitoring and or for blood draws. Some of these catheters may have antimicrobial surface treatments, and if it does, the catheter will state AGB+. For a multi-lumen catheter, the distal lumen is designated for central venous or CVP monitoring, TPN, and also for continuous infusions. The distal lumen should not be locked except with a provider order. Many times, the catheters are referred to by their insertion site and by the number of lumens. For example, you need to indicate the side of the body. It's either on the left side or the right side, and then the location, either in the subclavian, the internal jugular, or the femoral vein. And then the number of lumens could be a triple lumen, a double lumen, and a single lumen. So for example, the picture on the screen, you will see that this particular patient has a right IJ triple lumen catheter. Now that we discussed what a non-tunnel central line is, we are next going to look at the insertion, care, and removal of these lines. For insertion, we will look at these different items. We're going to go over patient education, informed consent, insertion bundle, the procedure, the site selection, verification, and complications. So if the patient is awake or aware, you will want to provide teaching prior to insertion. That's including information about the procedure, what to expect, and provide information on central line associated bloodstream infection prevention. Oftentimes, the central line placement can be an emergent procedure, and the teaching may need to occur after the line placement when the patient is awake and aware. The signed consent by physician and patient is the ideal prior to line placement. But like I mentioned, oftentimes this is an emergent procedure. So if family is not at the bedside for consent, providers can attempt to reach family over the phone to achieve consent, which the nurse will be a witness to. If there is no next of kin available, providers are able to perform a two-provider consent in an emergency. Preventing infection and complications are key. Use the central line bundles for insertion, care, and maintenance for CVCs. The bundle branch is most successful when all elements are executed together in an all or nothing strategy. There are 5 key components to the central line insertion bundle. The first, of course, is hand hygiene. The second is for the insertion of a central venous catheter, you want to make sure you use maximum sterile barrier precautions, including the use of a cap, mask, sterile gown, sterile gloves, large sterile drape, and sterile gel and probe covers. The provider inserting the catheter needs to cleanse the intended site with chlorhexidine for 30 seconds unless contraindicated by age or allergy. The antiseptic solution must be allowed to dry before making the skin puncture. If the patient is allergic to chlorhexidine, 1% tincture of iodine is the preferred alternative, followed by povidone iodine. For neonates, povidone iodine is the preferred alternative rather than the 1% tincture of iodine. You want to make sure you refer to the policy for the approved indications with the line placement. The provider will select the optimal catheter site for the patient. Physicians with proper training will insert non-tunnel catheters. One of the things that the provider needs to determine is the appropriate site for insertion based on each individual patient. The most commonly used veins for central lines are the subclavian vein, the internal jugular vein, and the femoral vein. The preferred insertion is the subclavian vein, as it is the shortest route to the superior vena cava. However, patient-specific factors, the physician's skills, and relative risk of mechanical complications need to also be considered. The subclavian vein has increased blood flow around the catheter, resulting in minimal catheter irritation or obstruction. This site lowers the risk of post-placement complications, resulting in longer catheter life. Some of the disadvantages are that it increases the risk of a pneumothorax, vascular injury, and death. So absolutely no intern may place a CVC above the waist without a fellow or attending present. The internal jugular vein is the preferred alternative site for non-tunneled central venous access. Some of the advantages are that it's easier to cannulate the subclavian, it's a straighter shot to the superior vena cava, and then the disadvantages are that it's difficult to secure and maintain an intact dressing. There is greater vein irritation due to catheter movement. Occlusion can occur with head and neck movement, and there are decreased patient comfort and mobility. The femoral vein is strongly discouraged in adults and pediatric patients. Utilization of this vein is at the discretion of the provider based on safety and health conditions. So when is it a good time to use a femoral for a central venous line? It's a good selection when the EJ, the IJ, or the subclavian placement is contraindicated. So it's great quick access in emergency. And then the X-ray confirmation may be desired, but it's at the doctor's discretion, which makes it good to use in an emergent situation. Some of the disadvantages are that it's difficult to access on large patients. It's difficult to secure and maintain sterile dressing. It also limits the patient mobility. And there's an increased infection risk due to the location. Now that we talked about the different locations that the line can be placed, let's talk about the actual procedure itself. Non-tunnel catheters are placed by a physician at the bedside. The provider needs to have proper training and supervision. The bedside nurse monitors the patient and observes the procedure. So as the bedside nurse, what exactly are you looking for? You will be looking for the patient's tolerance and the sterility of the procedure. Maximum sterile barrier precautions must be used, including cap, mask, sterile gown, sterile gloves, and a large sterile drape. And so that's including you as the nurse. If you are in the room, you want to make sure that you have a cap and a mask on. If you are to help the physician hand anything over, you may have to put on sterile gloves. A pre-insertion checklist in the EMR should be completed with all central venous catheter insertions. The patient positioning during the procedure is per the doctor's preference. That's also including the insertion location and the patient's capacity to tolerate the position. So if the patient can't tolerate lying flat, this may not be the best position for the patient to be able to lie for that line placement. So from my experience, it can take anywhere from 30 minutes to 90 minutes for a line placement. So take this into consideration. You may also help the physician by clearing and cleaning the table for the sterile field, so you're prepping that room for your physician. And then also make sure that there's no visitors and other procedures that should occur during line placement. So the key thing to remember for insertion is that if the sterility is compromised, it is your role to speak up. After the catheter is placed, it then needs to be verified prior to use. A chest x-ray post-insertion of the central line is not only done to confirm the placement of the catheter, but it's also done to assess for post-insertion complications. The desired location of the catheter tip depends on the site of the catheter is inserted. If the line was placed above the waist, such as the subclavian or the jugular, the line will terminate in the superior vena cava or the right atrium. If it was placed below the waist, such as the femoral vein, the line will terminate in the inferior vena cava. A chest x-ray is not required. It will be based on clinical assessment and the patient status, and is also dependent upon the physician. So prior to use for the central line, you must have a doctor's order stating that it's okay to use after the tip is located or the tip is confirmed. The lines placed by radiology or in IR do not need additional x-ray confirmation because it's done under fluoroscopy and they're able to see the line immediately after it's placed.
So just like with any procedure, there are complications that can arise. So insertion complications that can occur with central line placement include hemothorax, pneumothorax, and also air embolism. Hemothorax is blood in that pleural cavity, and pneumothorax is air in the pleural cavity. Both of these prevent the adequate oxygenation and ventilation for patients. Symptoms include chest pain, shortness of breath, difficulty breathing, crepitus, so that it feels like you're palpating bubble wrap, kind of like Rice Krispies underneath the skin, tachycardia, hypoxia, and also hypotension. So those are all signs and symptoms of a hemothorax or pneumothorax. So how do you think that you treat a hemo or pneumothorax if your patient is showing symptoms of one? Let's find out. So just like with any other patient concern, the first thing you're going to do is assess your patient. You're going to look at those ABCs, their airway, their breathing, the circulation. How is the patient doing? Are they hemodynamically stable? What is their heart rate? What is their blood pressure? How are they breathing? Are they breathing? What is their oxygen saturations? Those are all questions that you're going to ask yourself and assess on your patient to gather those symptoms and those signs on your patient. If symptoms are occurring during the placement of the line, you need to have the provider stop immediately. Notify them, have them stop the insertion of that line. You're going to need an x-ray, and chest tube placement will likely be needed. You can see on the screen here 2 different x-ray images with arrows pointing to either the hemothorax or the pneumothorax. You're going to place an occlusive dressing to the attempted insertion site, and you're going to observe and assess that patient frequently. You want to continue to keep an eye on those signs and symptoms to make sure that they're not worsening, that they're not progressing. So keep a close eye on them. So an air embolism is when air enters the venous system through an open catheter. So this can happen when catheters and lines are not primed prior to insertion, when the catheter lumens don't have those little connection caps, those clear links at the end. Also during deep inspiration when the line is being inserted or removed. And also if there are any cracked hubs and catheter fractures. All of those things can cause an air embolism. Symptoms of air embolism include chest pain, sudden shortness of breath or dyspnea, coughing, hypotension, tachyarrhythmias, altered LOC, and also JVD. All of those can be symptoms of an air embolism. So how do you think that you're going to treat an air embolism? Let's take a look. So again, just like the hemo and pneumothorax, you're going to assess your patient. You're going to look for those ABCs to see if the patient is hemodynamically stable, if they're breathing. Again, you're going to stop the insertion of that central line if it is occurring when that line is being placed. You're going to want to place the position Trendelenburg on their left side. This is actually going to minimize the migration of that emboli. So you want to make sure that they are in Trendelenburg position on their left side. You're going to want to, again, place that occlusive addressing to that attempted insertion site. You're going to want to administer oxygen, and you're going to observe and assess that patient frequently. Air embolisms can cause a more emergent situation. So if your patient does go into a code situation because they stop breathing or they lose their pulse or go into a dysrhythmia, you're going to want to administer BLS and call for help. So if that patient requires you to do so, activate those emergency response systems. Get your coworkers in there to help do that CPR, help bag the patient while you're waiting for additional support to arrive.
Since we just talked about the insertion of the lines, now let's talk about the care of these lines. Remember, you want to use the central line bundle for insertion care and maintenance for central venous catheters. Once the catheter is inserted, it is the nurse's responsibility to know how to care for the catheter. The central line maintenance bundle has 8 components. Remember, part of the bundle is to perform a daily review of line necessity with prompt removal of unnecessary lines. The 8 components of the central line maintenance bundle is listed on the screen for you. I'm not going to go over it and read every point for you, but take this time to go ahead and read through the 8 components. Here are some general measures and guidelines when caring for a non-tunnel central line. Each shift, a nurse must document nursing assessment of the catheter in addition to the central line maintenance bundle elements in the EMR PCS flow sheet. In neonates and pediatric patients, evaluate the catheter insertion site every 1 to 2 hours with continuous infusion, and then evaluate every 4 hours or per visit for locked catheters. You want to consider using a continuous IV fluid infusion rather than a locked CVC with any intermittent therapy. This will help prevent introduction of infection in addition to preventing catheters from occluding. An infusion pump should be used for continuous or intermittent infusions. Insertions should be documented in the EMR by the provider inserting the line, and the nurse must also document the line in the EMR. The provider completes a CLIP form, which will transfer over to the EMR, and the CLIP form stands for a Central Line Insertion Practices form. Whenever possible, designate one lumen exclusively for TPN if a multi-lumen catheter is used. Do not use the percutaneous introducer sheet to infuse TPN. The use of a femoral CVC for TPN administration requires an order from the physician. You also want to designate one lumen for any infusions requiring trough levels. It is preferred to not use the lumen to draw trough levels as this can provide incorrect lab results. Dressing changes should be completed every 7 days for adults and pediatrics. Wait, what happened to this? Just like you scrub the hub, you will need to provide junction care prior to accessing IV injection ports and prior to tubing or needleless connector changes. So you want to assess the site and dressing condition every shift and upon admission, transfer, and after a procedure. You want to also assess the patency before initial use or upon accessing a locked lumen. You also want to verify positive blood return and that the line flushes without difficulty before use. So for a sluggish blood return, consider administration of alteplase. So you can see the policy 13041, and that policy is the declotting central venous catheters using alteplase.
So we already talked about the insertion of non-tunneled catheters. We talked about the care of the catheters. So now let's dive into the removal of these non-tunneled catheters. Once the central line is no longer indicated for your patient to have, the nurse must follow protocol to remove that central line as soon as possible. This not only will decrease the risk of that line being infected, but it will also decrease any other complications that the patient may get from having that line in place. So part of the removal process is performing patient education, and we're also going to walk through the procedure at the bedside. So just like with any other procedure or intervention that you're going to do on your patient, you're going to want to provide patient teaching, give them that education prior to removing that line. So you want to explain the procedure to the patient and the caregiver family that they have at the bedside prior to going in there to remove that line, so they know what to expect during this process. You also need an order before you can remove that central catheter. So you need a provider order either when the indication is no longer requiring the patient to have a central line, so the therapy is complete, if there is suspected contamination of the line, or if any type of complication is identified, that line needs to be removed. But before you can remove it, you need that order from the provider. Prior to removing a central line, you're going to want to establish peripheral IV or alternative IV access. So we did go over some of the complications that you can have when the line is inserted. You can also have complications when a line is being removed. So you want to make sure that you have other IV access that you can utilize if an emergency situation arises. So a non-tunneled catheter may be removed by a nurse with that provider order. So you're going to want to gather all your supplies before you go and you start your procedure. You should also be aware of potential complications that can occur when that catheter is removed and how to initiate emergency measures as necessary based on those complications. So some of those complications include resistance. So if you're feeling resistance when you're attempting to remove that catheter, stop and notify the provider. You don't want to continue to pull when you're feeling that resistance. Another complication is catheter embolism. This is when part of the catheter breaks off. That's why it is so important to inspect those lines post-insertion. When your line is removed, you want to look at that tip of that line and see if it's intact. That's why that question is an epic. Is that line intact? Because if part of that catheter breaks off, that is actually considered a medical emergency, and the patient is going to have to go to either IR or surgery to remove that catheter fragment. Another complication is air embolism. We previously went over this as a complication during insertion. It is also a complication during removal of that line. The last complication we're going to talk about is bleeding. So if you're unable to stop bleeding from the site after catheter removal, continue to hold pressure. Notify the provider if the continued pressure does not achieve hemostasis, but you do need to continue to hold pressure on that bleeding site. So here on the screen is the process of removing a non-tunneled central line. We are actually briefly going to go over each step listed here. The first step is patient positioning. You're going to want to place the patient supine flat or Trendelenburg position unless contraindicated. You want the level of the catheter below the level of the heart during the removal, as this is actually going to decrease the risk of an air embolism during catheter removal. You're also going to want to have the patient turn their head away from the catheter. It gives you a better view of the site and also decreases any type of contamination to that site after you clean it before you remove the catheter. So, first things first when it comes to dressing removal, you want to turn off all the infusions that are going through that line to the patient. The last thing you want to do is pull that catheter out while those infusions are still going. The next thing is put on a pair of gloves. Remove the dressing and inspect the site of that catheter. You're going to want to culture any purulent drainage that is around the site of the catheter, but only if you have a provider order. The next thing you're going to do is site disinfection. So you're going to want to disinfect the catheter and the insertion site prior to the catheter removal. If you're culturing the catheter tip, you're only going to want to use an alcohol swab stick. That's it. Only cleanse with alcohol if you're going to culture the tip of that catheter. If you're not culturing the tip, you're going to disinfect the site with chlorhexidine for 30 seconds and allow to dry. If the patient is allergic to chlorhexidine or if they are less than 37 weeks gestational age, you're going to use povidone iodine and let it air dry for 1 to 2 minutes. You're then going to remove the sutures and any securement devices that you have on the line. The next step is the actual removal of the catheter. You're going to want to instruct the patient to hold their breath, to exhale slowly, or to hum as that catheter is gently withdrawn. If the patient is not able to do any of these items, then you're going to want to remove the catheter during exhalation. All of this is done to help prevent that air embolism from occurring. Using sterile gauze, you want to apply gentle pressure to the site while slowly withdrawing the catheter. If you feel any resistance, stop. Never forcibly remove if resistance is encountered. That forcible removal can result in the catheter fracturing and embolizing, which remember, that's a medical emergency if that happens. You're going to want to apply firm, constant manual pressure to the insertion site for a minimum of 5 minutes and until bleeding stops. This means that regardless, you're going to be holding pressure on that site for at least 5 minutes. Even if there is no bleeding to occur when that catheter is withdrawn, you still want to, per policy, hold a pressure there for a minimum of 5 minutes or until that bleeding stops. So it may be longer than 5 minutes if the patient continues to bleed. You're going to want to examine that catheter to make sure it's intact. And if ordered, you're going to send that catheter tip for cultures. After removing the catheter, you're going to apply a petroleum-based ointment or petroleum gauze to the exit site for 24 hours and cover with some sterile gauze pads. Position that patient per comfort. Your patient is going to want to maintain bed rest for at least 30 minutes after that catheter is removed. You want to keep that site dressed for at least 24 hours and change that dressing every 24 hours until the site is healed. For assessment and documentation, you're going to want to observe your patient for any respiratory distress, change in vital signs, change in their level of consciousness, and notify the provider if any complications occur. Inside the electronic medical record, you're going to document the removal of that line and how the patient tolerated the line removal. If any of those complications arose, if you had to speak to the provider about anything, you also want to document that conversation in Epic. Certain dialysis catheters are also non-tunneled, such as the Quinton and the trialysis catheter that you can see here on this slide. According to policy, as a nurse, you're able to use the power-rated third port, which we commonly refer to as the side port, just as you would any other non-central line. So you're going to want to refer to the dialysis and apheresis clinical policy, which is policy 7509, for use, care, and maintenance of these lines. Remember, the bedside nurse is able to change the dressing as these lines are considered non-tunneled central lines. So you're going to utilize the same process and frequency previously mentioned for our non-tunneled central lines. So if your dressing needs changed as it's been 96 hours or the integrity is compromised, part of the dressing is peeling up, you want to do so in a timely manner to prevent that catheter from getting a catheter-related infection. So just know that you, as the bedside nurse, can change the dressings on these catheter lines. However, these catheters are different when it comes to removal. Although these are considered non-tunneled central lines, these dialysis and apheresis catheters can only be removed by certain healthcare providers. So when you receive an order for your non-tunneled apheresis or dialysis catheter to be removed, you want to contact the apheresis nurse for those non-tunneled apheresis line removals, or contact the dialysis nurse for the non-tunneled dialysis line removal. You want to determine a plan for the patient to have that line safely removed in the shortest time possible. The longer a line is in place, the more potential that patient has for infection.
So the last type of central line catheters we will be talking about is tunnel catheters. Tunnel catheters are used for patients who require long-term therapy. These catheters remain in place for years and provide long-term access. The tunnel catheters are large bore, and they also have a single, double, or triple lumen, and they also have an antimicrobial cuff at the exit site. The antimicrobial cuff secures and protects the tunnel from the external environment by stimulating granulation tissue to grow around it. So after the granulation tissue has grown in, microorganisms cannot migrate along the tunnel tract, which reduces infection risk. The tunnel catheters must be inserted surgically. The physician tunnels the catheter under the skin and into the superior vena cava. After the catheter is placed, the catheter is secured with sutures for 2 to 3 weeks until the granulation tissue has grown around the cuff. So although these catheters are much more expensive to insert, their maintenance is more cost-effective than the non-tunnel catheters. For the care and maintenance of tunnel catheters, it's very similar to that of the non-tunnel catheter. The frequency of dressing changes, the site care, administration set change, and nursing care is the same besides what is listed on this slide. So for dressing changes, you can perform the procedure either with a sterile or clean technique, and this is all dependent on your patient. The sterile technique needs to be utilized if your patient is immunocompromised, has a prolonged hospitalizations, they have multiple vascular access sites, and if they are in critical care. And then don't forget to, when you're doing the sterile technique, that you will be using the sterile central line dressing kit. Now for the clean technique, this can be done with low-risk patients, and also if the site is healed after 7 days, as long as the catheter's cuff is not exposed. I would say err on the side of caution and utilize sterile technique when you're unsure. And then don't forget to use the chlorhexidine sponge disc, or also known as the bile patch. In the acute care pediatrics, do not use the bile patch on healed catheters. Hey, thanks for joining us.
If you have any questions about what we discussed today regarding central venous catheters, please refer to the policies listed here on the slide. We look forward to seeing you in person for the in-person skills portion. Enjoy the rest of the presentations.
Bye.